A very warm welcome, dear companions, ladies and gentlemen, colleagues, to this case in point session entitled Morphologies to take you further across calcium morphologies. My name is Michael Haude. I'm your anchor person of this session here, and I'm not alone here. I'm together with my facilitating team. On my left side, Jonathan Hill, who will be the spokesperson of that session here. He's going to take care of your questions. You can send in either by the app, or you can also, if possible, use the stand-up microphones to pose your questions. And then we have our four presenters here, Claudia Cosgrove, Carlo Di Mario, Com Hanratty, and Stefan Harp, who will give us thoughtful insights into the different topics. Now, what are we talking about here in that session? It's about calcified lesions. We are aware of the fact that this is one of the biggest challenges we have to face in interventional cardiology. We nowadays know exactly that we have different kinds of calcifications, superficial ones, deep ones, more circular ones, even napkin ring-like appearances of calcification, and very challenging scenarios where we have eccentric calcifications, which are protruding like a nodule into the lumen. And we have an armamentarium which can address these kind of calcified morphologies, and one of that pieces of armamentarium is intravascular lithotripsy. And this session is about the usage of that technology, and we have to appreciate that this technology is celebrating its 5th anniversary this year. So that's the reason why also we are doing this this symposium here. Now, the objectives are for you to understand the mechanism of action of intravascular lithotripsy for the treatment of calcified lesions, to learn about latest improvements in the technology, and practically to uncover tips and techniques for IVL in challenging calcified lesions, diffuse disease, left main bifurcation, and eccentric and calcified nodules. Now, this is the flow of the session. We have 4 presentations. Claudia Cosgrove is going to give us an insight into the fundamentals of intravascular lithotripsy and the new Shockwave C2 Plus catheter. Carlo Di Mario will give us an example on usage in complex diffuse calcified lesion. Com Hanratty in the second scenario of a calcified left main bifurcation lesion, and Stefan Harp in eccentric and nodular calcium. And at the end, I'm going to give you and provide you a short wrap-up of that session. So without any further delay, I would like to ask Claudia to give us an insight into the fundamentals of intravascular lithotripsy and the new catheter. Claudia, please.
Okay, so this was to be a comprehensive overview of lithotripsy in 5 minutes. So let's see how we go. So extracorporeal lithotripsy has been around for 30 years, initially in the treatment of renal stones, and where it was found to disrupt calcific renal stones but leaving soft tissue unharmed. And it's been miniaturized and loaded into a balloon for use in the intravascular space. And the energy profile, or the energy emitted, has also been appropriately modified for use in this space. So the emitter that's in the fluid-filled balloon generates an electric spark that causes a vapour bubble to expand and then collapse, which produces the shockwave. And because the acoustic impedance of soft tissue is similar to that of water, it doesn't have any effect on soft tissue, but when it encounters a tissue with different impedance, such as calcium, there's a rapid dissipation of energy and it causes fractures. So, again, this is a nice graphic showing the process of the vapour bubble expanding in a circumferential way, collapsing, generating that first shockwave, and then the collapsing of the bubble generating a smaller second shockwave that travels in a circumferential way out. Because it's of similar impedance to water, soft tissue is not harmed or affected by the shockwave, but calcium, both superficial and deep calcium, is fractured. So when the shockwave encounters the edge of the calcium, it causes compression, and then as it travels through the calcific lesion, it causes a shearing effect, when it encounters the outer edge of the calcific deposit, there's both propagation and reflection of the calcium, which causes a sort of a tensile pulling apart effect. And there's also a squeezing effect due to different speeds of the calcium, the shockwave through the calcific tissue compared to the surrounding tissue. So you can see that through these sort of multiple mechanisms of all these actions, it causes fractures in both in multiple directions, and it causes large fractures and it causes microfractures, as opposed to, say, a non-compliant balloon that might cause simply radial fractures. The lithotripsy, as you can see on the right, causes fractures in multiple planes. We can see these fractures on intracoronary imaging, and particularly well appreciated perhaps on OCT with radial fractures, and then on the longitudinal view, the longitudinal fractures are visible. And these undoubtedly play a large part in achieving compliance of the vessel and then facilitating stent expansion. However, the other effect of lithotripsy that's really unique are these microfractures, and they are so small they're beyond the resolution of OCT and can only be seen on either microscopic CT or on histology. And you can see these pictures pre and post IVL that show these microfractures again in all different planes. Histology has also shown that the lithotripsy has an effect on both superficial and deep deposits of calcium, and this is a really unique action of lithotripsy when compared to other calcium modification techniques. And again, micro-CT shows these microscopic fractures that we know from the CAD3 study play a large part in achieving optimal stent expansion, even in the absence of fractures that are visible on OCT. The Shockwave C2 Plus is the newest iteration of the coronary shockwave balloon, and it essentially has more pulses per catheter, so 120 pulses per catheter as opposed to 80 pulses from the on the previous catheters. And this may be useful in a number of situations where we think more pulses are required to gain the same effect. So previously, lithotripsy was thought most effective in concentric calcium, but increasingly it's recognised that it has indications in eccentric and nodular calcium, and obviously more pulses will be effective in longer lesions. So in concentric calcium, there's a reverberation effect that amplifies the shock waves, and so perhaps fewer pulses are required to achieve satisfactory modification. But in eccentric and nodular deposits, there is an effect, but it may just require more pulses. When we're working out how to effectively use the pulses, intracoronary imaging really plays an integral part in using the pulses most efficiently, and I think we're going to hear in the next couple of talks a bit more about a pulse management strategy in terms of tailoring or targeting the site of your pulses to get the most out of them. So in summary, lithotripsy restores vessel compliance through multiple and unique mechanisms, including causing fractures in multiple planes, causing these microfractures, and also the ability to modify both deep and superficial wall calcium. The Shockwave C2 Plus catheter has 120 pulses, which may be useful when we are treating long calcific lesions and also in nodular and eccentric calcium. And to use the lithotripsy most efficiently and effectively, we need to have a pulse management strategy targeting the catheter to where it will be most effective. Thank you.
Thank you, Claudia, very much for this really educational overview. It comes more or less always on the topic, should we need always use all pulses, so either 80 or 120? And how do you, or how many pulses per location you recommend to apply?
Yeah, I think that's difficult to answer. I think I usually try to use all the pulses just to get our money's worth. But I think often you can see that the shockwave balloon is underexpanded initially, and then when you have delivered sufficient pulses, you see expansion of the shockwave balloon, so that's very reassuring. I think other factors may determine how many pulses you use, such as how well the patient tolerates the lithotripsy. But certainly expansion of the balloon is probably the most useful metric, I think.
Jonathan, questions from the audience that popped up already?
Not so far, but Claudia, perhaps I could ask you at what point in your use of intravascular lithotripsy, because you've been using it for a number of years now, at what point did you realise that there was efficacy in nodular and eccentric? Was it early on, or is that something that's come more recently?
Well, definitely more recently. I think initially we all, were restricting it to use in concentric calcium, weren't we? And so we wouldn't use it in eccentric calcium. But more and more it's sort of crept into our practice, and I've, anecdotally had some very successful cases with good stent expansion with it in eccentric lesions. And then, the evidence is coming, I think, there's as to its efficacy. Yeah.
Maybe I could ask the same question to Colm, Stefan and Carlo. I mean, have you been using this for eccentric nodular calcium right from the outset?
No, I think that we moved to use it more often on nodular calcium and eccentric calcium based on the data that we had from Disrupt showing similar areas, similar expansion. I mean, coming back to the question of Michael on when to stop, I think the key point, because you don't have IVUS during the application of your device, is to look in two views when your balloon is fully expanded. This both for peripheral use when you use lithotripsy before the delivery system of a TAVI or in the coronaries. Once you see full expansion, I think that's the time you can possibly stop. But I always have 20 pulses in a calcified area where I expect to need the full effect of the energy from the ultrasound assessment before.
Thank you, Carlo. Not being unkind, but in order to keep our time schedule, we need to continue. It's my pleasure now, Carlo, to invite you to give us your example on the use of IVL in a long, diffuse calcified lesion.
Thank you, Michael. So I have a somewhat easier task than Claudia, since I'm simply describing the very first case that a few months ago I was able to do with the new C2 Plus catheter. And among my conflicts is the fact that I've been using this technology for the past 5 to 7 years, including the first Disrupt 1 and 2 trials. This is the patient and the lesion, 80 years old. Just simple exertional angina, no history of myocardial infarction, but still, you see, there is a hit in the inferolateral wall. Ejection fraction is 45%, and NT-proBNP is definitely raised, but good renal function. And if you look at these 3 angiograms, you see a very long calcified segment, a double rail, especially at the level of this large diagonal branch in the proximal LAD, and beyond you have most of your calcium, but definitely there is involvement also of the left main. The circ is limited to a posterolateral branch, and there is occlusion of a marginal with a very large and not critically ill right coronary artery. So you may say how to treat. Normally I would have pre-dilated, inserted an OCT or an IVUS catheter, and acted upon them, but I know that I need some sort of technology to modify this calcium, and of course if I don't cross, I would go for the rotational atherectomy. In this case, you know, I have gray hair. I'm a little bit like a schoolboy when I have a new tool cool and a new toy. In this case, was my very first C2 plus catheter, and I said, well, let's see whether it goes. What Claudia maybe didn't tell you is that the crossing profile is the same, didn't change. So there is no particular reason to believe that this is crossing more than the previous catheter. But Jonathan did with me many of the initial cases with the initial catheter that was bulkier than the current one. And still in 60% of cases, we were able to have it without predilatation if you choose a proper backup from your catheter and maybe guide extension. So this has the big advantage and the big difference that it can deliver more energy, half more energy, 120 pulses instead of 80 pulses, and rapidly within 12 cycles. How do you administer this energy when you have a long lesion? I think many of us have tried to use a single 80 pulses catheter for such a lesion. Results are unlikely to be very good because you don't deliver enough energy to these extremely calcified areas. While here you can apply the following strategy. You withdraw half of your balloon so that you have your distal marker at the level of the more proximal of the two emitters, and then you are sure that these 10 millimeters of vessel segment is properly addressed by the energy of your devices. And if you repeat this cycle for the 120 pulses that you are available, and you deliver, very important in my view, 20 pulses, so you keep your catheter still in the same position when there is severe calcification, and you deliver a double series of pulses, you will achieve, in most cases, the result you want. This is theory. In reality, also in this case, didn't work exactly the same way. Maybe I started a little bit more distal, so I did a single series because the balloon immediately expanded. But you see, when you see these areas where the balloon is severely indented and you need several pulses for the balloon to open up, you may need more than 20. In this case, in two different positions, I use 60. So I finished my 120 approaching the left main, but without being able to truly treat the left main, also because was what I felt was the correct balloon for the mid LAD, so a 3.0 millimeter balloon. So then we went with the intravascular ultrasound, and you see that we started at this level in the normal segment of the artery. Up to there is normal, is a 3 millimeter, beautiful distal vessel. And then you start to see your calcification, facing calcium, 360 degree calcium, 270 degree calcium. Also, of course, OCT gives more brilliant images, but also intravascular ultrasound shows the cuts, the fractures that you induced in this calcium at this level. So if this is the level of this large diagonal branch that you have here in the longitudinal view, you have the possibility of implanting a 28 millimeter distal stent to make sure that you don't overlap the two stents in the area of the origin of the diagonal branch. And this allows you to go 3 distal and 3.5 more proximal. That's what we did. But then there is the left main area. And here, of course, we didn't apply much lithotripsy. There is a single small fracture. There is enough calcium, both in the polygon of confluence and at the very origin of the LAD, that's the circumflex opposite to the origin of the circ. In my view, to justify more application of shockwave. Proximal is a very large 6 millimeter vessel. So you have all the information you need to plan your procedure. 28 millimeter distal stent. Once you have implanted them, you have to deal with this bifurcation we did with the drug-eluting balloon. Then you implant a more proximal stent helped by the stent boost with minimal overlapping. Then you do your pot. In fact, we had to do, I don't show, another 2 millimeter balloon to optimize the result on this diagonal, but after that stayed very well. And then once you have secured the result in the mid-distal LAD, we worked on the left main, a 4-second shockwave balloon, and we managed to get it fully expanded, and we concentrated on that eccentric calcium, all our 120 pulses on that. You have heard from Claudia, we may need more energy for eccentric calcium. That's what I believe, and that's what my experience. You are asking yourself, okay, you have an open right coronary, but 45% ejection fraction. Do I need an impeller for that? Not necessarily. If you are quick enough in your inflation deflation of the balloon, you will create enough space to have flow after the 10 seconds of occlusion of the delivery of the energy. That's the way you will work if you are using a normal balloon. The balloon will be grossly unexpanded on one side and will act most of its energy towards the side branch, in this case the left circumflex, and creating, of course, plaque shift and carina shift, reducing the ostium of the left circumflex. If, on the contrary, you don't rely on pressure, you use 4-6 atmospheres, but the energy to rupture the calcium is the one coming from the vapor bubbles, that's what you achieve. Multiple fractures, longitudinal and tangential, and at this point you will be able to fully expand your balloon without impairing flow in the ostium of the side branch. We then implanted a 4 millimeter balloon of the correct length calculated with ultrasound. That looks a generous size for this pot, but was measured with IVUS and was 6 millimeter. And as expected, the left main is excellent. That's the wire for the circ. You do have some possibility of improving result in the mid-LAD in the area of 360-degree calcium and some distal malapposition, not the end of the world, but you can easily optimize with a larger balloon. That's what we did, and this is the final result. We actually didn't go for kissing balloon for this circ that, as you see, is limited to a relatively small posterolateral branch, and anyway, has excellent flow. So this was our outcome, and my conclusion is that having a greater number of pulses on a single IVL catheter allows effective delivery of lithotripsy over longer segments, potentially up to 60 millimeter. You need to have an effective delivery, to have a meticulous planning, and this can be easily guided by intravascular imaging to select the diameter of the balloon, very important, as to be against the wall, ideally without air. Prep your balloon very well, redo it after the first delivery of pulses if air develops inside, and to identify the locations where the lithotripsy has to be focused. And eccentric calcium is, of course, still a question mark. You may say, I can do with balloon only. Personally, when you want to optimize the result, especially in large bifurcation, my strong advice will be to take advantage of the lithotripsy energy. Thank you.
Carlo, thank you very much. Quite a number of questions come into my mind. One is, when you do your pulse management according to the intravascular imaging, how important is it to have a co-registration of the imaging into the coronary artery to then identify in your tree, where is your working method, the coronary angiogram, to identify where to apply more pulses than regularly?
Yeah, it's a very good question. I mean, I think it is anyway very important to have a good longitudinal pullback and measurement. For the electronic system, you do need co-registration, otherwise you can't measure length, right? While for the Boston system or any mechanical system, you have a length measurement during your pullback, but you miss the co-registration. And I confess, I tend to like more and more the possibility of knowing exactly where that particular ultrasound cross-section is located on your angiogram, because at the end you have to place your balloon on the angiogram and not on the IVUS.
A little word on the competition in the long calcified lesion between this IVL technology, in particular the new catheter, and ablative technologies, rotablator and in particular orbital atherectomy, where you see where the role is.
Yeah, doesn't cross, you have no answer. It's obviously rotational atherectomy. I don't have enough experience with orbital atherectomy to really tell you a final answer, especially for nodules. I think nodules, you may really need the best of the two worlds to achieve an optimal results. Having said that, I confess the vast majority of the lesions I treat are uncrossable rotational atherectomy when a balloon goes with lithotripsy, and results are excellent.
Thank you very much.
And now that you have the possibility of treating longer segments, you miss one of the potential driver of using more rotational, that is, you use a single device for a long lesion.
Thank you.
So I think an important related question that's come from the audience, and that relates to debulking, or the concept of debulking. And the question is there any advantage in IVL effectiveness or a disadvantage to debulking with rota first, even if it's not a balloon uncrossable lesion? No. So for this case, did you ever see a role for rotational atherectomy for debulking that left main?
Right, I confess, I don't think that was going to make a real change in the final outcome. And besides cost and complexity, I think the ablative technology have an inherent risk that is not really present with shockwave. Safety, as you know, is the main advantage of IVL. You never have perforation related to this technology, while unfortunately, especially for tortuous lesion, it cannot be
You've done a lot of
same
these
with
cases.
I think the ablative technologies don't really debulk. You know, it's modifying the calcium. So we've moved away from large burr towards calcium modification. So it's not as if you're debulking. But they are complementary technologies, and it's very unusual that you will use one of these technologies in isolation. So it's quite common that you will use rotablation and then use shockwave, or use shockwave and use cutting balloons. So they're all complementary technologies.
There is a recent published article by Sardella in JCC Intervention on that, and some are our cases. I confess most of them were uncrossable to start.
One more question. So it's from Sadat Edrus, who's online. And the question is, if you see good calcium modification on intracoronary imaging after shockwave, is there any need to dilate the modified area any further with a non-shockwave balloon prior to implanting an appropriately sized stent? Very important question, particularly in long calcified lesions.
Yeah, I agree. It's a very good question. I personally think that this was a bit my strategy in the past, using a single balloon for a long lesion. Sometimes you don't crack enough your calcium and your expansion is not perfect. Personally, I think now that you have more pulses and more energy, use that to achieve an optimal outcome. And hardly ever I use pre-dilatation after shockwave before stenting. I will do a final post-dilatation because there is always something to optimize based on your final imaging. But between lithotripsy and stent implantation, hardly ever I need another balloon.
Okay.
Thank you so much. I think, looking at the time, we need to proceed. We still have time to discuss further on. It's my pleasure now to invite Han Ratti, who's going to provide us a nice case of a very calcified left main bifurcation lesion and the application of IVL here.
So thank you very much for the opportunity to speak here. And I'm just going to share with you a case that we did as a live transmission to Malaysia. 85-year-old gentleman, left main disease, 111 bifurcation, and for PCI treatment. So these are the setup shots. So this is a 7 French radial system. We're expecting that it's going to be calcified. We're expecting a 2-stent strategy. and this is at 7:30 in the morning. So this is an epicranial shot. And then this is a spider shot showing the angulation into the circumflex, not the most wonderful angiogram. We use low fluoro rates with our angiography, which does affect the image quality for these sort of broadcasts. But what we've got is, in terms of the still, we've got a calcified distal left main stem. So anybody that does live cases knows that you want to select a live case that you're going to get done. And they also know that when you go live, you want to be at least started in the case, if not well on your way towards finishing it. And the reason I say that is because the patient went on the table at 7:30, and the plan was to IVUS both branches and be set up to do the broadcast at 8 o'clock and get on with the case. There was a slight delay in the transmission. This is 8:05, and I don't have a wire in the circumflex, and I can't get equipment into the circumflex. A balloon will not go. This is a coil-based microcatheter Mambiflex trying to get into the circumflex to deliver a rotofloppy wire to drill the circumflex. So I've gone live, and we are nowhere near started. And I'm sure we've all been in this situation. So what do you do? Okay. So I performed IVUS off the LED back into the left main just to be seen to be doing something. This is it on fast, and what you've got is an area of very heavily calcified concentric calcification in the LED. That is the bifurcation. You can see the wire at 7 o'clock from the circumflex, and I'll show you a few stills of this. So the left main is 5 millimeters, not a lot of calcium in the left main. There is the bifurcation. You can see the two wires with dense calcification, 360-degree concentric, and probably the most dense calcium is at the ostium of the LED. And there is our distal reference, which is a 3.5 millimeter vessel. So at least this has given us some very helpful information from the LED back into the left main, but of course doesn't help us in terms of crossing. So this would be the wire across uncrossable lesion that you would see in CTO-PCI. So the first thing you do is try and get a small balloon across. That didn't go. We then switched to a coil-based microcatheter. That didn't go. We could use anchor options, but of course the side branch that we're talking about is the main LED. And so we're into higher risk strategy. So if we cause disruption in the LED and the equipment won't go into the circumflex, we're pretty much all in. Tornus, we're going to use a tornus to try and get around that angulated circumflex to deliver a rotofloppy wire. Personally, I don't think it would work. Rotablation only works if you can get a wire across. We can't get a microcatheter across. We can't do a wire exchange. And while laser will go on an 014 wire, personally, I don't think laser has much use in this degree of calcification. Remember, laser has been around for quite a long time. He delivered on the wire that's there. So if laser worked in extreme calcification, we would be doing it more commonly. So I don't think it really works. So anyway, what do we do? And of course, what we're trying to do is modify the calcium to affect the compliance to deliver our equipment. You've seen from Claudia's excellent talk the physics behind shockwave and the C2 plus balloon. So what we have is a wire in both branches. So theoretically, these pulses are coming out perpendicular to the emitters. So theoretically, you are likely to get disruption of the ostium of the side branch from a balloon in the main vessel. And Claudia explained this in great detail, how you get the disruption in the calcium. So theoretically, this should work. So what we did was we used a 3512 shockwave balloon. Actually come up quite quickly, and I'll come on to how many of the pulses you deliver. I personally don't use all the pulses. I keep some in reserve for a reason I'm going to explain in a minute. And we did intravascular imaging after this with the pre and the post showing disruption. You can see the fractures and you can see the wire in the circumflex. So we've modified the left main. Have we modified the circumflex? So I've got an anchor balloon in the LED in case I need it. And this is now a 2.5 balloon coming round unimpeded into the ostium of the circumflex. So remember previously, a 1-2 balloon wouldn't go, a microcatheter wouldn't go. We've delivered shockwave to the left main LED. That has modified the ostium of this heavily calcified circumflex branch to allow us to deliver equipment. So I didn't have to use the anchor balloon. After that, we put in our stent. So this is a 3532 Megatron. We need another stent at the distal edge, which I'll show you. Performed our pot. Now, I keep a bit in reserve. There was an area of underexpansion on the imaging after stent implantation. You saw that also in Carlo's case. So this is the 3.5 shockwave balloon delivered to that area to deliver more pulses. So even though the balloon came up, even though the imaging suggested we got a good result, when we did our stent implantation and post-dilation, there was a still area that was constrained. So with 120, I'm keeping some in reserve in this situation, and if needs be, I have no hesitation in terms of shockwaving a freshly deployed stent, especially if it is an abluminal polymer stent. Okay, we've spoken to the engineers in Boston and Abbott. We've done some stuff in this with Rob Byrne in Dublin. So I think the shockwave in a freshly deployed stent will affect the polymer on the luminal side, but it will not affect the metal. This is the angiogram and the intravascular imaging, and it showed that we got very good result, an area of 10 millimeters squared at the ostium of the LAD at that very tight area of 19 in the left main, and a very good distal edge. So without this technology in this situation, we're taking the patient off the table to have a discussion with the cardiac surgeons, or talking about coming back for an LV-assisted all-in strategy to try and get equipment into the circumflex, rotablate it, and we've talked about the risks associated with that. So thank you for your time.
Thank you very much. A very, very interesting case. It brings into my mind how you precisely make the decision which size of IVL catheter you use in this left main bifurcation scenario, because the daughter vessels are somewhat smaller, the distal vessels. So you prefer to take the smaller version, or you prefer to take the larger version in order to get attached to the vessel wall in the left main?
And I think that's an excellent point, especially when we're talking about the 120 and going for a longer lesion length. Are you sizing it to your distal reference? Are you sizing it to your proximal reference? You know, and I'm not sure. I do tend to size towards the distal reference, and remember the disease was so extensive in the left main stem that we had opposition. But you could, in Carlo's case, for example, maybe go on with a 4.0 for your distal reference, go to low pressure, and then, you know, so this is up for discussion. I know what your thoughts are, Jonathan.
I think at the moment the convention is to size to the distal, but if you're going to stent the whole segment and you really want to get full apposition in the left main, then maybe it doesn't matter so much if you get a little bit of a distal dissection at the end of the balloon into the LAD, but I think most people would size it to the distal.
I think we should consider that this is not really a dilatation balloon.
Yeah.
It's an application balloon. Even if you take it a little bit larger, it's not really creating dissections, not at all. Yeah.
Colin, that was a fantastic case. The graphics are fantastic as well. There's some really interesting questions that are coming in. There's three I'm going to ask you, so quick responses. One is about dose. Does IVL have a dose-dependent mechanism of action?
In what way? The more you give...
the more... Are more shocks required for more calcium?
I think it's going to come down to the density of the calcium. And I think we're just beginning to understand that. And if you look at the ultrasound and you see reverberation, that probably suggests that the calcium isn't as dense. So I think there's a bit of work to be done. I use as much as I need to do the job. I don't use all pulses in all situations.
Okay. The second question relates, and I think you did address it, that in cases like this, do you have to choose a stent with more radial force like Synergy Megatron?
Yeah. And I think for aortoosteal work, you know, it makes sense.
Okay. And the last question, and there have been a few of these, relates to the use of shockwave within a freshly deployed stent. I mean, you've explained why you're comfortable with it. Do you think it's a stent, it varies from stent to stent?
So remember the initial data showing the pitting on the stent?
Yeah.
And that just didn't resonate because, you know, it's not like stents are layered. And if you speak to the engineers, a stent is a solid piece of metal all the through, so why should it pit? I can understand if you have a polymer on the luminal side, you will affect the polymer and strip the polymer off. But we know that happens going through calcified lesions anyway. The Synergy stent is an abluminal polymer, so you're not touching the polymer, you're touching the metal. I've spoken to the engineers in Abbott, and Boston on this, and no engineer can give me a good reason why you would get pitting. We've done some studies with Rob Byrne in Dublin, and the stents are being analysed as we speak. I think it's a non-issue.
Okay.
But I think clinically it's a balanced question of risk on the one side, which means stent thrombosis, versus maybe restenosis on the other side. So an underexpanded stent, honestly speaking, I would not risk to leave in a lesion like that.
The biggest risk to the patient is the underexpanded stent.
Yeah.
So I think, we don't do it all the time. And I think when a stent is in, I think you're more likely to get reverberation off the stent. So I speculate that you may get more effect with a freshly deployed stent, but that's hypothesis generating.
Okay.
A very hypothetical question for you, in particular when we talk about large left mains. 2 devices at the same time applying if you have a second engine generator?
It's been done.
I know, but this is why I bring it up. I mean, if you need to get contact to the vessel wall.
Yeah.
But if your vessel is that big,
but
if your vessel is that big that you need to take 2 devices, what are you trying to achieve? Because you're going to get a very good area, and we know from IVUS and XL, if you get over 12 millimeters squared in your left main with your area, you're going to do very well. So do you need to go for complete?
No. Well, I think you showed beautifully, that graphic shows it beautifully, of how the ostial segment of the circumflex was modified by the balloon in the left main LAD. I think that's pretty clear, and I think we can all understand that.
Yeah.
Well, good. Thank you so much. And then we move forward to the last lesion subset. Stefan Happ is going to present the eccentric calcified nodule and our treatment options that we do have there.
Do I have to close this?
Yes. No, it will come up.
Thank you, Michael. I'm waiting for this to come up. I have the good role that I can do the last talk. Most of the things have been said already. So what I think would be nice to combine all the knowledge in this case that I'm trying to share with you now. The case is about an 80-year-old lady. She's a small lady. Imagine the small lady, body mass index is really low. She's not the adipose lady you usually have in your cath lab. And she's coming with acute dyspnea and really heavy angina. But her coronary artery disease has been known for 5 years already. There's lots of risks: renal insufficiency, diabetes, and a very bad peripheral arterial disease that really made the surgeon shy away 5 years ago from taking her case on because he was not finding any grafts. She was on good medical therapy, antihypertensive, ASA, statin. And at admission, she showed this ECG. She was it was a little bit hypotensive, but not in shock. As you see, the heart rate is only about 80. The ECG was done twice in a short time frame, while the troponin was rising. And you see there are ST changes that are dynamic. But actually, even though the therapy was very modest, I'd say, an echo was done also, you see good function. You see some aortic stenosis, and the therapy was only liquids. She had a dry tongue. They just gave her a liter of saline, and she was feeling better. There was no specific, nothing specifically done. Blood pressure was good again. While she was actually discussed, I was going to our files. We have the luxury to have the files of all of our provincial hospitals accessible. So like if the helicopter is coming and the patient has been there, I can prepare. And this was actually the angio 5 years ago. 5 years earlier, she did have this right, this more or less dominant right with just this single stenosis. And if you looked at her left, you will realize the LAD is really a badly diseased vessel with a lot of stenosis. And if you look carefully, you can see this angulation here, where the arrow is pointing at. And just keep this in mind, keep this morphology in mind, because it's important for my case. And if you look further, you will find that there is a CTO of the mid-circ, And there's also subtotal occlusion of a branch. And I don't know, I mean, Jonathan, you do many cases. Would you take on that chronic total occlusion in this 80-year-old lady, or would you hope not to have to do it?
I would hope not to have to do it.
Me just as well. CABG had been planned then, but never got done. She had these infections in her leg, and she was in a bad state. And she was suffering, but she's a humble lady. She wasn't outspoken and said, oh, she wasn't complaining every day. Typical for patients like that. 5 days after admission, it's a shame. It's non-STEMI, STEMI, even almost 5 days after admission, we did the angio. Not too much different from the first angio, a little more diffuse disease now. There's something new in the left side. You see this, what I would call like a stable nodule maybe in the left main, but maybe it's just a thrombus, even though after 5 days with heparin and stuff, that should have gone away. There was still this morphology in the circ area where we cannot really specifically address it, I think, in this stage. So we were thinking, is this left main thrombus? Is it calcified nodule? Actually, the case was presented to the surgeon again, and it was decided that there was no way we could help her surgically. And this was also decided we could not expect to help her with mechanical support. So what would be the strategy now? If I get the case back now, nobody really wants to do it. I think, what can I do to better the perfusion in this heart, in this well-functioning heart? And I see this rather simple stenosis in the right, and a lot of the circumflexes depending on that also by collaterals. So I decided to rotablation on that right artery. Because why did I not go for shockwave? It might have been possible. But if I occlude this for a while doing the pulses, I think she would her blood pressure would drop and maybe not come up again. So I did this just normal rotablation, went easily, and I could take a breath and was happy. So now I addressed the left side, seeing that we have a lot better perfusion. This nodule was still there. Now I call it a nodule because I don't think a thrombus would stay the same way all this time. And I also realized when I put the guide there, the guide was just stopping there. It wouldn't stop at a thrombus, but it stopped there like there was a really bad resistance. The IVUS didn't pass either, because we have learned we have to do the imaging first and then decide what to do. In this case, no way to even pass the nodule. So, and you remember the angulation again? And we now did just put in the wiring was actually easy, and you see the movement of this turnpike here. When I came in last night on the motorcycle from the airport, I passed through the traffic in Paris. It was a little bit like the movement of the motorcycle through the traffic. So rotablation was started, but I couldn't get it across this angulation I had pointed at in the beginning of our case. It just wouldn't work, you know. I would not force this here. I don't want to perforate in this case. I don't want to perforate in any case, but especially not in this one. So it was actually stopping there, losing speed. I couldn't go ahead with rotablation. We could have taken a larger burr maybe, but I decided to try to go for a different strategy, to go to balloons again now. So I just left the rotor wire in, put a second wire next to it, took the good balloons I had on the shelf, and then I stopped with the larger balloons again at that angulation. I couldn't pass with larger balloons. And so I decided to use shockwave antegradally. So I wanted to try as much as I could to approach a little bit similar to Colm's approach with the bifurcation, hoping there would be some antegrade or to the side effect that might loosen up this angulation. And what happened after 40 pulses, this expensive balloon ruptured, but now I was able to put in the IVUS. And so I put in the IVUS, and you see this calcified, the remnant of the calcified nodule, and you see a lot of calcium there. And so I thought, I approached my boss, let me have another one of these great tools, because this will not work with balloons. So, and in the second attempt, I did get in the shockwave, the second shockwave IVL, all the way down distally. And it did all the pulses I did apply, because I do not keep it in reserve. If it is necessary, I will ask for a third balloon. And but I was using one effect. You know, you see that usually the wire is is a little bit biased when you start shockwave, and it's starting to be unbiased for showing effectiveness, so you don't have to repeat this IVUS all the time. And this was I was a little bit too fast. This was actually the cracked plaques, the many cracked plaques. So this is jumping a little bit, but I want to show this picture. You see many cracked plaques, many cracks here. Except for the angulation, it was a very good result. There's some dissection distal of the angulation, so I'm always thinking if I could do it with drug-eluting balloon. In this case, I stented it. And I stented it not as you were learning with a good stent that can have some radial force. I just used a very thin strut stent. This was the post-stent IVUS. And I'm finishing now with this slide. I tell you that I like a rotor, but rotor may fail. You cannot force it. Use balloons, good balloons. IVL, in my opinion, is a very special balloon. You see this box here. This box is presented to gentlemen to shoot at each other. These are two very good weapons. So IVL and rotor are both very good weapons, but I do not suggest to have them shoot at each other. It's not device against device. It's device supporting device for the good of our patient. And I want to have one more sentence to calcified nodules. We were already addressing this, but I didn't get a chance to talk. Hope it was good because we saved time that way. You know, we have these eruptive nodules and we have the stable nodules. And I want to address that the eruptive nodules are still really a thing we don't know what to do. But we have a theory that is coming from the vessel compliance problem. You know, if there's sheets of calcium cracking at the spot where the most force is keeping it eruptive, keeping it like a volcano. So indirectly, I think shockwave may help, not by hitting at the nodule, but by breaking up those sheets. Thank you.
Stefan, thank you. Thank you very much. One thing I would like to know from you when you address a calcified nodule by IVL, how you exactly position the emitters of the IVL catheter according to the nodule.
If, like in this case, I know exactly where it is, I can see it on angio, I can see it on IVUS. I know that, as Claudia has told us, we have the most effect in between the emitters. So I make sure that in between the emitters, I use the emitter distal and proximally. And what I did in this case, I moved a little bit distal, a little bit proximal, just a few millimeters. So I also used the full radial force coming from the emitters. So this, I think, has to be carefully done, just like Carlo alluded to. I cannot really do it to the whole stretch of the vessel. I'd like to do that because in my dream, we'll go away from stenting and prepare the vessel in a way that the very radial force is not needed as much anymore. So this is a dream, but we'll get to that.
Jonathan, do we have questions?
Yeah, we have
audience.
Yeah, we have quite a few questions. So going back to nodular calcium, and in particular, I think the nodular calcium we saw in this type of case, is a question about restenosis. So what about restenosis after nodule treatment in IVL? And this question is saying, in my practice, I've seen restenosis of nodular lesions at the same place 12 months later. I think we're all seeing that, aren't we?
Yeah.
That these eruptive nodules erupt again.
And this is why I'm raising the point, because maybe it's not about hitting at the nodule, but hitting at the sheets to make the vessel more compliant, to have the force less to this volcano.
Stent fractures mechanics, you know, that these are causing because of torsion within the vessel, especially if you think of a right coronary artery which moves 3 centimeters with each cardiac cycle, and then you put in the stent, and the stent's fixed here and moving in between. That's a stent fracture model. So I think what you're seeing is shear forces at that point causing the nodule and then leading to stent failure. But I don't have a solution for it.
Yeah, nobody has.
So there's a question also about IVL efficacy. So I think this is born out of concerns about balloon inflation in the left main. It says, if you deliver very short runs, so 3 to 5 pulses at a time, but achieve the same total amount of pulses in patients, do you have the same effect?
I suppose so.
I think it's a dose-related effect, isn't it? The more pulses, the more calcium modification there is.
It is interesting how well it is tolerated. You know, it's only up for 10 seconds. You know, it comes up all the time, and you'll see people putting an LV support because you're going to use IVL in the left main. You know, it's obviously you got to assess each individual case, but patients tolerate it very well. I think Carlo made the point; it's very efficient balloon inflation and deflation.
If they do become hypotensive, you can just withdraw it into the guide for a few seconds, and while their blood pressure recovers.
I think we're seeing the use of IVL in patients with very severe LV dysfunction, perhaps also with concomitant valve disease. And I think there are those types of case where even with the first balloon inflation, you become non-pulsatile. And that's where
absolutely
it's preferable to have an impeller in place rather than doing cardiac massage.
Absolutely. And you know, it's always easier after the case to say when you should have put in the impeller.
Yeah.
Jonathan, for the last minutes that we have with this symposium, I would like to address to all of you here in the panel the same question. You are all high-frequent users of that technology. What would you like to be seen to be improved? What do you want to see better as we have right now? Carl, we start with you.
Forward-facing.
Okay. Quick answer.
You took my answer. That was mine too.
Yeah. So you have a second option.
No, I think forward-facing is the next thing coming, isn't it?
Yeah. So I think it's a universal device that a crossing device as well as a modification device.
Carlo.
Number of pulses are very important. I mean, I'm a big user of peripheral balloons as well. You know, those 300 pulses that you have in peripheral arteries are super powerful. Remember, the central emitter has even more energy than the others. I mean, you see results in these super calcified, very thick plates of calcium in external or common iliac arteries that look unbreakable, and they are open up at 4 atmospheres. I think we will wait the C2++ for the near future.
Stefan.
Forward-facing combined with imaging, so that I can come forward without forcing the catheter through the stenosis and just pave my way through there and see it's fine. Hopefully it becomes true before I die.
You have some time. No, if I can also give my option, honestly speaking, when I look at the calcified nodules and I see how much energy already right now we have, I would like to have a device that is focusing the energy on a certain kind of angle rather than going 360 degree, in particular for these scenarios, which allows me to steer and focus on the nodule. That's my wish. So the company knows what to do, what to improve. I think it's now time to conclude that session. I'm more than happy to do that. So I think we had a quite fruitful session, and I tried to bring it down to 3 bullet points you can see here, which is summarizing what we have seen and heard. First of all, IVL is an effective and safe technology, no doubt about that, to address all kind of coronary calcifications with a favorable ease of use. Do we have the slides on or not? Yes, we have. You see them. That's fine. You don't see them, but they see them. That's the most important thing. Thank you so much. The new C2+ catheter, second bullet point, with 50% more pulses, allows even to address more complex calcified lesion scenarios. You have seen that here. You have seen longer lesions. You have seen left main bifurcation. You have seen calcified nodules. And I think what comes around quite clearly, pulse management is extremely important, and this is ideally based on intracoronary imaging, and this is essential, at least for these very complex calcified lesion scenarios. Having said that, I personally want to thank all of you, also on the name of Jonathan, to our 4 presenters here, to you as the audience here, and more or less, now I'd like to finish that session and wish you a very fruitful rest of EuroPCR 2023. Thank you so much.